All right, so O2 tension indices. So this is probably one of the, if that wasn't hairy, it's one of the probably equally hairy parts of pulmonaries, where we talk about the delivery of oxygen. So the DO2, how much oxygen is being delivered to the lungs, right? Or sorry, to the body, to the tissues. And then we have the tissues oxygen consumption. How much O2 are the tissues using? That's called the volume of oxygen, right? So volume of oxygen. So if my tissues using more oxygen because they have a fever, or more oxygen because they have a seizure, more oxygen because they're in pain or agitation, these are things that can increase my VO2, right? And we have to recognize that because we can fix those things. We can fix seizures, we can fix fevers, we can fix agitation, we can fix pain, right? We want to reduce the amount of oxygen they're using, reduce like myocardial oxygen demand, reduce oxygen demand of the diaphragm that might be breathing at 40 breaths per minute in a 76-year-old. That can be a problem, especially if the delivery of oxygen doesn't meet that demand, right? That's going to lead to, that's what usually leads them to the ICU. Okay, so we'll talk about the components of those, and then we have SpO2. That's the saturation of our hemoglobin, right? SpO2 and SaO2 are both the saturation of our hemoglobin. SpO2, the P stands for pulse ox, right? That's the pulse ox saturation, right? Whereas SaO2 is a saturation measured on the ABG machine. It says this is your actual saturation, right? SpO2 is just an estimate. It's not an actual number, right? It's not actually say, oh, look, it's exactly 93%. It just compares things. So that might be it, right? We talked about AA gradient briefly. We'll talk about the more useful PF ratio, which is like the poor man's AA gradient, because when you actually do an AA gradient, it gives headaches, right? And P50 is a number we can attach to our favorite thing we ever learned in school, which is called the O2 hemoglobin dissociation curve, right? So this thing is, it's important to recognize, yeah, when my temperature's up, I'm going to demand more, my tissues are demanding more oxygen, right? When my CO2 or my acid levels are up, when I have acidosis, right, with pH that is low, that's going to make my tissues require more oxygen. So I got to fix those things, right? And we can actually have a number right here called the P50, which we can actually get the actual where in the O2 dissociation curve we are. Okay, all right. So yeah, so this patient right here, they have all this edema going on, right? So that's going to be a poor VQ, a low VQ. But then on the other side, what is the actual delivery of oxygen, right? The delivery of oxygen has different components to get to my tissues, right? How do I deliver oxygen to my tissues, right? My DO2 is going to suffer when I have this pulmonary edema, but now we're on the other side of the alveolus. So the first section we were all talking about the alveoli, right? Now we're talking about the other side, okay? All right, so these are the ones we're talking about again, DO2 and VO2. To calculate these ones and to understand what they're talking about, we got to talk about CO, not carbon monoxide, but what does CO stand for? Cardiac output, right? So cardiac output is, if I'm delivering oxygen to the tissues, that depends on my cardiac output, right? If my cardiac output for my heart, right, is not great, that's not going to deliver a lot of oxygen to my tissues, right? They call it a poor output state, right? When your patient has really, really bad CHF, really, really bad cardiac output, you can assess them. You can assess their extremities are cool. They're not getting good blood flow. They're in a poor output state, right? And then we have the arterial content of oxygen. How much oxygen is actually in that blood? We're not talking about the delivery, like the squeeze, which the heart was doing with cardiac output. We're talking about how much, whatever it squoze out, or whatever the past tense of squoze is, right? So you're squeezing out all that oxygen with your cardiac output, then what is actually in that blood? If I were to sample it, what is in there, right? Then that depends, and because that's going to get to the tissues in that beat, right? So we want to make sure that oxygen that gets delivered to the tissues has good content to it, right? And that depends on the hemoglobin, right? Have a hemoglobin of 14 versus 7, that's going to make a difference, right? So that's we're going to deliver less oxygen when we have a hemoglobin of what? That's 7 or 14. Which one's going to deliver less oxygen? 7, right? So it's just like a train car analogy, right? If I deliver, the train's coming up to the station, to the alveoli, and it's going to pick up oxygen, right? If there's only 7 cars and it's rush hour, it's like, well, shoot, now you're going to be waiting in line for a long time, right? So to make sure we have enough cars to carry our oxygen, right? Enough baskets, enough train cars to deliver that oxygen to our blood, to our tissues, right? Our tissues being down here. So hemoglobin is an important piece, and SaO2. What's SaO2 again? Arterial what? Little a means arterial, but it's the saturation of our hemoglobin, right? So if it's, for instance, I have 14 cars, I have 20 cars, right? My hemoglobin is 20. but then it comes up to the alveoli, and all the alveoli drop off for four little measly oxygens, right? Well, that means you probably got pneumonia or something going on, but it wasn't able to pick up a lot of people. And they come back to the tissues, they're just like, what the heck? Where's my oxygen at, right? Because the hemoglobin's like, what? That's all I could pick up, right? There wasn't that many people, and not many oxygen. I was unable to get a lot of oxygen from the lungs, right? So arterial saturation, how saturated are my hemoglobins, right? And then we have the PO2, kind of the same thing, right? So how is oxygen carried in the blood? Is it carried mostly by hemoglobin or mostly through the bloodstream, dissolved in the bloodstream? Which one? How do you transport hemoglobin in the bloodstream? Hemoglobin. How do you transport oxygen in the bloodstream? Because hemoglobin is the right answer, right? So 97% of your hemoglobin, of your oxygen is carried on your hemoglobin, right? The other 3% is dissolved in the bloodstream, right? It's really hard to dissolve gases inside of a liquid, right? It's usually just bubble right out, right? So only 3% of it actually stays in the bloodstream. The other 97% gets attached by our hemoglobin, right? So it's important that our hemoglobin can get saturated, and the PO2 does play a small role, only a little 3% role, right? But it can be significant, and we can measure that on the ABG, right? So SpO2, that's our pulse ox, right? The better pulse ox or the better saturation would be our hemoglobin. And then we have the P(a)O2, right? That's our arterial O2 content, our arterial O2 that's dissolved in there. If that's low, that is hypoxia. And we got to see a little bit of, what's the problem? Was it a problem with perfusion, right? My train is arriving to the station, but it's stuck because there's a PE in the way, right? Or there was a lung process that made it get less oxygen. Okay, so all of this is the DO2, the delivery of oxygen, right? So that's all of this over here, right? The delivery of oxygen, the oxygen supply to my tissues. Arterial content, that contains the how much of the hemoglobin is saturated and how much O2 actually got into the bloodstream altogether. Like the PO2, again, that's the alveolar, right? Alveolar oxygen concentration. What if my PiO2, the inspired oxygen, right, was less? What if they were only on 2 liters when they required 8 liters, right? Their inspired oxygen was less, or they got narcotics. They're inspiring less oxygen, right? And that can impair how much oxygen actually gets to the alveoli in the first place. And that can then ultimately lead down to a lower oxygen content, right? We talked about diffusion briefly, like you have pulmonary fibrosis, you have thickened membranes, you have a problem getting oxygen across the alveolar membrane in the first place, right? And we can measure what's called DLCO, the diffusion of carbon monoxide. That's usually done like down the street at the pulmonologist's office. They can measure and see like, oh yeah, you have a problem with the alveoli. That's not something we really do in the ICU. Okay, and then we have cardiac output out over here. That's going to help with our VQ mismatches. But over here also cardiac output, that's also a key component of the delivery of oxygen. If my heart rate is 20, that's not going to deliver a lot of blood, right? And therefore not a lot of oxygen. If my stroke volume, I got a EF of 10%, that's not going to deliver a lot of oxygen, right? And then when we talk about hemodynamics and CHF and such, we'll talk about contractility, preload and afterload. All those things are going to affect this train arriving at the station, right? If I'm all vasoconstricted, right, that's not going to let this train get down to the tissues as much as it should. Okay, so that's what we're looking at for the delivery of oxygen. And then we have the VO2, right? So the VO2 is how much oxygen is the volume of oxygen being consumed at the tissues, right? What are the tissues consuming? So if you're febrile, your tissues are really, going really haywire, and they're using a lot of oxygen. If you're hyperthyroid, you're using a lot of oxygen. That's going to make it so, you got to deliver a lot more. If you're not meeting the demands, your body's going to start shutting down, right? And then you're going to start, firing off compensatory mechanisms like the SNS firing off, right? Breathing faster to maybe and then squeezing and try to improve cardiac output and trying to fix the underlying problem. Okay, and then P50. So we arrive at the station, but then the hemoglobin is starting to say, hey, no, I'm not going to drop off any more oxygen, right? So that's the O2 hemoglobin association curve where it decides am I going to drop off this oxygen or not, right? And it does it based on the tissue's oxygen level, right? If tissue A has a whole bunch of oxygen, tissue B does not, the hemoglobin is smart enough not to drop everything off equally between the two of them. It's going to drop it off where it's needed, where there's a lot of low pH, where there's a lot of CO2, where there's a lot of temperature. It's going to drop off more oxygen compared to the tissue that's not undergoing those processes. Okay, so that is the delivery of oxygen, the volume of oxygen, and then we can measure on the other end the SVO2. And really, we can't really stick a fork in this to say, oh, your VO2 is this. That's not how that works, right? So we actually we just subtract the DO2 from the venous side, the arterial side from the venous side, and that can get us an idea of what the volume of oxygen is. But usually we don't really get an absolute number. We just got to recognize what is raising my patient's oxygen demands. Okay. All right, so DO2 again. So here's my DO2 here. Here's my VO2. So just to explain that again, we have what's DO2, what are the parts of it, and the amount is usually about 1,000 mLs a minute. And we're delivering 1,000 mLs a minute, which includes our cardiac output, which includes the O2 content of my blood, or the CaO2. All right. So how much oxygen is actually in the blood that I squeezed, and my squeeze is affected by stroke volume, how well my heart was able to pump, and it can be affected by my contractility. Sorry, by stroke volume or heart rate. Stroke volume times heart rate is my cardiac output. If I have dysrhythmias, I'm an AFib RVR at 170. That's not going to let my heart fill up with blood, and therefore my cardiac output is going to be less, and the oxygen to my tissues is going to be less as well, and I'm going to have some chest pain. I'm going to have some shortness of breath, some hypotension and confusion as well, right? As I get less blood flow to my brain. Okay, so if there isn't blood flow, you're not going to have O2 delivery. And when your tissues don't get O2, they go into a protective mode where they start making lactate, right? That's a way for them to go into debt. Let's use their credit card. Say, I know there's no oxygen right now. I'm not getting a paycheck of oxygen. I'm going to use my little debit card called lactate, right? And the lactate builds up, and they can then cash it in later. Okay, and then we have the O2 content, like we mentioned before. Right, you want to keep your little train cars with about 7 grams, or at least 7 grams, right? At least 7 train cars. So you want your hemoglobin to be full, or you want to have at least as much more than 7 grams of hemoglobin. So when we start getting more and more anemic, we have less oxygen delivery to our tissues, and those are the symptoms of anemia, right? They get pale because they have less blood flow to their tissues, right? They get exercise fatigue because they can't deliver enough for what the tissues require. Okay, and it could be hemorrhage, it could be chronic, and there's other blood tests we can do that we'll talk about in hematology briefly. Okay, and 1 little gram of hemoglobin carries about 1.34 mLs of oxygen. So why is that important? Because that's kind of part of the formula. That's just why you see 1.34 there. Okay, so my O2, my hemoglobin needs to be there, but then also how much saturation is of that 1.34 molecules of oxygen that can carry, how saturated is my hemoglobin, right? And usually it's about 4 molecules of oxygen for every hemoglobin molecule, and it usually drops off about 1 oxygen at the tissues. Okay, and again, that's dependent on this curve over here. Okay, so O2 on hemoglobin, that's 97% of the oxygen. Only 3% of it actually gets dissolved in the bloodstream, right? So the O2 dissolved in the bloodstream doesn't really participate in much oxygen delivery. It's important, but it's only 3%, and then of that 3%, 0.3% of that actually gets to the tissues. So really, it's the hemoglobin that's doing the heavy lifting, right? So that's why you see this 0.3% here of the arterial oxygen concentration. So another way you can think of this is, if you're a manly guy and you're going to only doing 1 trip of groceries from the car to the house, right? You're going to get 3 bags or 10 bags, and that's your hemoglobin, right? You got 10 bags of hemoglobin, and I got all my oxygen in there, or apples, you could say, right? Or my groceries. I'm bringing all of that to the house, and then that's 97% of the groceries. Where's the other 3% going? I'm going to put a watermelon in one armpit. I'm going to put I'm going to attach a carabiner on my back, and it's going to have my other, the watermelon over there. So it's going to be, that's the other tiny little 3%, right? So and then how fast you walk is your cardiac output. So that's the delivery of oxygen to the tissues, right? And then the tissues, that's up to them about how much they use. And as we know, a lot of the oxygen will then unload from the hemoglobin, not really the other little pieces outside of the hemoglobin. Okay, so yeah, so your systemic oxygen delivery is compared as your cardiac output, right? Which is your stroke volume times your heart rate. And then your arterial O2 content. What's your hemoglobin? We're going to keep it more than what? More than 7, right? So you should transfuse to greater than 7. And then we have our O2 saturation, right? How saturated are hemoglobins? We want them to be saturated, but we accept 88%, and we'll explain why just 88%, right? When they're like 99%, 100%, it's like, oh, I go full throttle. All my patients have 100% sats. That actually is deleterious. It causes more problems than good, okay? And then PO2, that's what's dissolved in the bloodstream. That's 80 to 100, right? That's our ABG, okay? So that's our DO2, that's the delivery of oxygen to our tissues. And then our tissues themselves, they are going to start using oxygen, right? So our tissues are going to start using oxygen. That's the volume of oxygen they're consuming. They consume about 250 mLs a minute. So, well, I've given 1,000, 250 is nothing, but you got a lot of patients that come to the hospital, right? So they have to start requiring, there might be a drop in their hemoglobin because they're anemic or they're hemorrhaging. There might be a drop in their cardiac output because they're here for a CHF exacerbation. Or they have a pneumonia and they have COPD exacerbation, so they have a drop in their delivery of oxygen, right? And then they have a fever. So now you have this drop, you have this pneumonia with a fever, so I reduced my delivery of oxygen, and now I've increased my oxygen consumption in my tissues, right? So that's going to really quickly going to start to mismatch, right? It is measured indirectly. We measure the SVO2 and partial pressure of oxygen on the venous side, and we can calculate roughly what it is. But we just want to think of it conceptually what VO2 is, right? It's the venous O2. It's the volume of oxygen that we are utilizing every minute, right? How much oxygen we're using, right? Our hemoglobins, again, can only carry about 1.34 mLs, right? So when do you use more VO2? Roughly when sepsis, fever, you're shivering, you got pain, anxiety, all these things are going to make us require a lot more oxygen. All right, you better make sure that when our hemoglobin arrives, that it delivers oxygen to those areas that have more fever, that have more acidosis, right? Okay, so VO2 versus D, what does it entail, right? So these are like the causes up here, right? And down here are the fixes, right? So what caused, we kind of mentioned some of them, right? They got agitation, they got pain, they're shivering, their work of breathing is hard, right? You got the diaphragm, intercostals, you got the scalene and the sternocleidomastoid all working really hard. They got this accessory muscle use, and they got a fever and pneumonia and COPD, and they got some CHF as well, and they're on the, so well shoot, let's take away part of the equation, let's put them on the ventilator, and let's take away all those extra muscles that are using oxygen as reroute oxygen to where it needs to go, right? So that's one of the things we could consider in someone that's starting to show signs of agitation, starting to show signs of desaturation because their O2 requirements are increasing because of these items here. So agitation is a big thing we try to fix in the ICU, right? Even on the floors, we try to control their agitation, control their pain. So we are reducing the amount of oxygen that they're requiring, and therefore we can meet their demand, right? Because their cardiac output might not be great if they have like CHF, right? Their arterial content might not be great if they have anemia, right? If they do have anemia, we can give packed RBCs, right? Their saturation is low. Right, the PO2 is low. We can try to figure out, is there something we can do to fix it, right? If they have a pneumothorax, we can maybe re-expand the lung. Or if they have a pleural effusion that's filling up one of the lungs, we can do a thoracentesis to improve the VQ mismatch, right? So when VO2 is greater than DO2, so when the volume of oxygen that's required every minute is higher than how much oxygen being delivered, that's going to start causing problems, right? So it starts causing hypoxia, and hypoxia can lead to shock, and then now it's a downward spiral from there, right? So we want to try to control those the best we can, okay? Now tissues can compensate a lot. They can do a lot of things to try to fix the problem, but only up to a certain point, right? And when you're older in age, it's much, much harder to compensate, right? That's why, when our 80-year-old patient is breathing really, really fast, or 80-year-old patient has a heart rate of 140 for a long period of time, that's much worse than a 26-year-old patient that with a heart rate of 140. Okay, how do we measure how much oxygen demand someone is undergoing? We can look at the lactate. All right, the lactate will tell us that the tissues are not, or have a deficit of oxygen. They're not getting the oxygen they need, and they're actually building up lactate. Right, lactate builds up when you don't have oxygen. All right, an echo can tell us how bad what is, how bad the heart failure is, or how bad the cardiac output is. Right, a PA catheter can tell us again how bad the left atrium is working, right? The left atrium is not working good. It's going to fill up into the lungs, and our pulmonary pressures can rise, and that's not going to help our forward flow of oxygen, right? A CBC, what's a CBC going to tell us? Hemoglobin, right? So hemoglobin has it on there. The white blood cell count being elevated can clue us in there might be an infection somewhere, right? Pulse ox, that's where we get our SpO2, and ABG can get our SaO2, but ABG can also tell us our PaO2, right? Tell us, well, shoot, the PO2 is 45. That's a problem, right? That tells us that why is that oxygen low, right? It can give us a firm objective number. Okay, so what can we fix on the DO2 side? We can fix the cardiac output a little bit. We can fix the hemoglobin. We can transfuse to greater than how much? Greater than 7, right? So greater than 7, it's like, why not greater than 8? Well, because there's transfusion reactions that can happen. So we don't, across America, we want to make sure we reduce the harm that could happen with blood products, all right? Really becomes a problem when your hemoglobin is less than 5. That's really the critical cutoff where you absolutely need to transfuse, and when it's less than 5, that's when you can have heart attacks, you can have a lot more problems, okay? So we try to prevent that by, at 7, 6.5, definitely we need to start transfusing, okay? PO2, we can increase the PO2 content by giving FiO2, right? We can provide FiO2, and that should improve oxygen delivery to the alveolus and hopefully get to the bloodstream, drop itself off on the hemoglobin, and also dissolve in the bloodstream, right? To improve the VQ mismatch. PEEP can be improved to improve our PO2 as well. So the two things to improve oxygen are PEEP and FiO2 on the ventilator, right? Those two things you're going to see hidden in every single vent mode, right? And BiPAP, there's a PEEP and FiO2, right? It's always there to improve our oxygenation, right? Saturations, again, how saturated are our hemoglobins? It depends on the O2 hemoglobin dissociation curve, right? They're less saturated when the tissues require more oxygen, right? They're going to drop off. They are good Samaritans, right? They are going to unload more oxygen where the tissue needs it, okay? Cardiac output, we can fix cardiac output sometimes. We can improve it with inotropes, right? Inotropes are improve contractility, and we can normalize heart rates if they're too fast. We can fix arrhythmias if they're causing, they can also cause clots, but we can fix arrhythmias if they're too fast or if they're too slow, like a bradycardia. We can improve the bradycardia, right? Stroke volume and heart rate, we can talk about heart rate, but stroke volume we can fix as well, right? We can give little boluses, we can give pressors to improve blood flow to the heart and also improve contractility to improve our ejection fraction, right? Afterload, we can kind of reroute blood and squeeze and maintain a blood pressure. And then contractility, that's where we have our inotropes. And our electrolytes, if our electrolytes are too high or our potassium is too high, that causes what effect on the heart? If the potassium level is too high. Cause your heart to stop working, right? Your heart needs the potassium. It does need potassium, but it's too high. It destroys the concentration gradient, and the muscle can't contract, right? So we try to fix those things, all right? And then VO2, we mentioned, like you might need to put them on the ventilator to fix their accessory muscle use, okay? And sedation, that's easy to give someone sedation who's on the ventilator, right? But in the meantime, usually on the telly or in an ICU even, we try to reduce their agitation as much as possible, reduce their work of breathing as much as possible. But sometimes it's the risks outweigh the benefits, right? Where they could cause respiratory depression, and they need that ventilation to get the oxygen in their system in the first place. Okay, so we can sedate them. We can even paralyze them. We can take off all the muscles offline and say your muscles are using too much oxygen overall. Let's shut everything down so that the oxygen can then be routed to the appropriate areas. Okay, and treating fevers, treating seizures, treating pain, anxiety. All these things are going to increase VO2, so we can fix that. Okay, so we talked about fixing heart rate and stroke volume, fixing hemoglobin PRBCs, improving oxygen content is our goal. We're trying to sustain the flow of oxygen to the patient. Okay, so that's our DO2 and VO2. All right, so saturation of oxygen. So what is saturation? That's how saturated or how much oxygen is on our hemoglobin itself, right? And we can measure measure that with a pulse ox, or you can measure that with an ABG, right? The ABG goes in there and it actually says, hey, your hemoglobin is this saturated, right? Or we can use a pulse ox, which just estimates how saturated our hemoglobin is, right? What's the advantage of a pulse ox, right? Advantage is it doesn't hurt, right? Does an ABG hurt? Yeah, it's one of the highest reported pains of any patient in the ICU, right? They pull a lot of ICU patients. They said, hey, what hurts the most? They said number one was ABGs. Number two was pulling out the chest tube. What? So yeah, pulling out the chest tube hurt the most. They probably didn't remember the insertion, right? So yeah, the A-line ABGs hurt the most. All right, so that's so that's one of the cons of or the benefits of an SpO2 is that it doesn't hurt. Okay, non-invasive, it's real time, right? Before 1977. If you said, you asked where your patient's SAT was, you had to get an ABG. SAT didn't exist, right? So they just had to say, yeah, they're getting blue. Let's get an ABG, right? You had nothing, no backup with an SpO2, right? So those guys back there in 1977, they're like, yeah, that's maybe like 90%, maybe, I don't know, right? So it requires no special expertise, right? Anybody can put a pulse ox on. You can buy it on Amazon right now, right? Doesn't require any kind of expertise. Punches out a number. You got to know which number looks good. Okay. Some things we can do in the ICU, and also you can do on the floor as well. But when you get a plethysmograph, which is the pulse ox waveform right here, that can tell you information about perfusion, right? And it's similar to an arterial line waveform. It's literally the pumping of blood up and pumping and relaxation, up and down, the squeeze and unsqueeze, or the systole and diastole of the heart. And you can measure that perfusion with your pulse ox. When your perfusion is not great, you don't have a great pulse ox, right? When you have cold fingers, that's not going to give you a great pulse ox. But when you have a good pulse ox, you can actually, it's validated, and it's actually similar to, you can say they have vasodilation happening or they have vasoconstriction happening. You can assess if they're in a shock state or not based on the pulse ox, right? So how do you know you have a good pulse ox? It's produced by Philips? No. How do you know you have a good pulse ox? Reading. Good waveform, yep. So you got a nice good waveform, that's good. This is not a good waveform, right? They got low perfusion in that state. What's another way you can assess they have a good pulse ox? Cap refill could be something that's kind of perfusion, but what else? The stars, right? They have to have a good Yelp review, right? So you got 3 stars. That is 3 out of 3 is our most we could get on the monitor. The monitor tells us they got 3 stars. We can pretty much trust the pulse ox, right? That's how good the signal is coming in. And then what's another thing you can look at to see if they have a good pulse ox reading? You can say, oh yeah, that's a good pulse ox.
Heart rate correlation.
Good, the heart rate correlates. So the heart rate says 71 and the pulse is 71, that is a good waveform, or a trustworthy waveform. Okay, so also in the ICU, you can do what's called, it's called max mode. So on the GE monitors, you just wave some magic, you say a little Harry Potter spell, and select maximum, and then it's for like ICU patients with poor perfusion. It actually gets you better readings. So in the pulse ox menu, you can just make sure maximum is selected, and it will actually get you a better reading, okay, for those that have poor perfusion. But as far as like your normal waveform right here, so that's normal, all right? Sometimes you might see a little notch, sometimes you might not, but you can tell based on the width or how wide it is or how narrow it is. You can tell if they are vasodilated in shock state or they're vasoconstricted when they're like dehydrated or bleeding, for instance, right? Because your body, when you're bleeding, you're going to try to compensate and squeeze, right? So when you're all squeezed right there, is it going to be easy to get blood into those tissues? No. So there's going to be a little bit wider when you are vasoconstricted. And when you're super vasodilated, all that blood's going to go out super easy, right? So you're going to be a little bit narrower comparatively. Okay, so you can tell about perfusion with your waveform analysis. You can tell about afterload, which is whether you are squeezing or not squeezing on your vessels. And you can tell about if you have AFib. You just look at the pulse ox. Oh, look, there's a little space right there. They got a little PVC, or there might be an AFib, for instance, right? Like this one has like PVC, PVC, PVC. A-line is cool, but pulse ox can also tell you that as well. All right, sorry, there's the SpO2 here, right? So pulse ox's advantages are as mentioned, but what is a good pulse ox? A good number, right? Where should it be? Where should your pulse ox numbers be? What saturation is a good saturation?
88 to 92.
Yeah, so 80 to 92 is usually where everybody should be at, right? If you are more than that, more power to you. That's cool, but we should not be doing more than 95% for someone that's on oxygen, right? So you take away oxygen when the stats start getting too high, right? It starts causing problems, as we'll mention about why that is, right? But if they have an MI or CVA, we'll accept 92, 95%, right? But never more than 95% on oxygen. That's going to cause more problems than good, right? This was really evident during COVID when patients were on really high oxygens and then they ended up getting really sick and had to come to ICU with ARDS because of it, right? So our goal is to make sure they don't get these hyperoxia complications. And can a pulse ox tell you if they're hyperoxic? No, they can't, right? You either 100% saturated or not, right? Once the hemoglobin is 100% saturated, where's the rest of the oxygen go? Into the bloodstream, right? The hemoglobin is inside the RBC, the rest of the oxygen goes to the bloodstream, and therefore that's going to be our, what measurement is that? The O2 that's dissolved in the bloodstream. PO2, right? And that PO2 can be all the way up to 300, 400, 500 sometimes. And that's going to start causing a lot of problems, right? Normal PO2 is what? 80 to 100 for a reason, right? It's not 80 to 120, it's 80 to 100, because when you're more than 100 sustained, it causes problems if you have that used more than 24 hours. Okay, so disadvantages of an SpO2. It's not a direct measurement. They basically just took a whole bunch of guys post World War II and had them eat, and after they ate after lunch, they took their measurements and wrote it down. Said, okay, this is what every pulse ox is from now to eternity. That's it. So doesn't assess women, doesn't assess African Americans with darker skin, doesn't assess these other things, right? So that's what pulse ox is. They just say, hey, we're going to deliver this based on these two signals that I'm comparing. That's the pulse ox that it is, right? There's no actual measurement going on. It's not going 92, right? All it's doing is comparing two infrared signals, right? And those infrared signals absorb X or Y. Your saturation is X or Y, right? So it's not a direct measurement, right? And it doesn't know if you have carbon monoxide poisoning, right? It just says your hemoglobin saturated with carbon monoxide is not good, right? But it could be saturated with oxygen, great, but it could be saturated with other things too. Okay, doesn't reflect hyperoxic patients with a PO2 greater than 100, right? There's no calibration. You just got good or 3 stars. It tells you, right? It's just was taken from non-hypoxic volunteers. When you have hypoxia, things going on in the tissues that might not have been assessed. Okay, so it's unreliable in severely hypoxic patients. When your stats less than 70, you can't trust a pulse ox, right? Usually like 75, you're probably really getting really concerned. But yeah, if the stats less than 70%, you can't say, oh, the stats like 54%. You see that saturation of 17%. It's just guessing, right? It doesn't know for sure. You can't validate that, right? That's obviously hopefully you got an ABG by this point, but you can't trust a stat that's too low. Okay, you got arrhythmias and poorly perfused. That can lead to errors in pickup and errors in perfusion, right? You got anemic patients, right? So again, it's empirical data. These were a whole bunch of 25-year-olds, post-war vets that just ate lunch. And do they all have a hemoglobin less than 6, 8? Probably not, right? They probably had hemoglobin around 14. So we can't always assess that it's 100% accurate. I'll give you a ballpark at least, though. Nail polish, blue and black nail polish will throw off the saturation about 3 to 5%, right? So if you have someone on pulse ox and it shows that they'll have like low sats, like because the nail polish is getting in the way of the signal, okay? And then dark pigmented skins, right? It overestimates by about 2%, right? So you have like a black woman trying to go get oxygen because she's short of breath all the time at home. She goes to your doctor's office. Oh, you're 93%. You don't need oxygen. We only give oxygen to people who have less than 92%. Well, now she doesn't get oxygen, right? Because it overestimated. Okay, so there's a whole thing there about that. All right, confused patients, all right, motion artifact, we know if you're confused, that's going to make the signal not go from point A to point B, right? So it's going to lead to inaccurate stats. And then ambient light, so it has to pick up the signal on the other side. If you have a beam of light shining in from the side here, that's going to interrupt that signal, right? So you just put your fingers underneath the covers with a hot pack, and you'll get great signals, all right? And great signals with how many stars? 3 stars. Okay, so again, how it works, we got healthy volunteers that volunteered their time to get their pulse ox measured, and they compared, hey, this guy was, and I'm pretty sure they validated with an ABG, but otherwise they said this is what, if I have this percent red light and this percent blue light, absorbed and not absorbed, that is my saturation. Okay, so it's not actually measuring anything. It's absorbing the signal or not absorbing the signal. All right, absorbing deoxygenated hemoglobin versus oxygenated hemoglobin is it's a test score, right? How much hemoglobin do I have? If I have 10, then this I have some that are deoxygenated and some that are oxygenated, right? That's the total potential oxygen that could be saturated, right? And then I measure with my blue light how much was oxygenated. That's going to tell me my percentage of sat or my saturation. Okay, so yeah, so the ratio just compares to a reference table in the monitor. There's nothing fancy that happens. Okay, so it's comparing one side to the other, and you get a display on the other side. Partial pressure of oxygen. All right, so we had SpO2 and SaO2 even. This is PaO2, right? So it's the oxygen that's dissolved inside the bloodstream, right? 97% of our oxygen was where? On the hemoglobin, and that's what the SpO2 estimates, and that's what our SaO2 actually is, right? But the other 3% of our oxygen is actually dissolved in the bloodstream, and of that 3%, only 0.3% is actually makes it to the tissues, right? But this other oxygen that's building up and building up and building up can start causing problems, right? And there is a correlation between how much PO2 I have and how much saturation I have, right? It kind of makes sense, right? If I have too much oxygen, it's not going to be able to saturate as well, and it's going to start spilling over into the bloodstream, right? And that's what the hemoglobin O2 dissociation curve is kind of looking at, right? Say, hey, you have a saturation here, your PO2 is here, all right? And we'll point that out. But PO2, what's a normal one? 80 to 100, right? And you really need to freak out when your PO2 starts getting to 50s. Right, when it's in the 60s, that's actually great, right? That's actually appropriate, right? Especially for a hospitalized patient and especially for an ICU patient. Okay, so when it starts, like you're like, well, shoot, 75 is abnormal and 65 is abnormal, but you know that's still okay. And why is that okay? Because we look at our curve and we can see if I have a PO2 of 60, that's a sat of 91%, right? 80 to 92 is perfect, right? So here's my stat right here, right? I got 80 PO2, which is normal. That's a sat at 95%, right? But if I have a sat of, let's say, 98%, right? 98%, that could be a PO2 of 150. If I have 99% sats, my patients are always 100%, always 99% every single time, and they're on a breather, right? Then you could have a PO2 of 200 or 300 or 400 or 500, right? 98%, when you're over 97, that's when you start getting, you can't really estimate what the PO2 is, right? So it's always good to have the stats about 88 to 92%, right? Except for which patients should have a little bit higher. So you got patients that need more oxygen, which would be ones that have an MI or a stroke, right? MI stroke patients will accept 92, 95%. But when you start getting higher and higher than that, more than 95% on this table over here, you run in the danger zone, right? Of our PO2 being too high. Okay, so it starts getting toxic over here, causing O2 toxicity. And there's a kind of quick like spatial mnemonic here, right? It's called 4, 5, 6, 7, 8, 9 rule. So you think of here's 4, 5, 6 over here, 40, 50, 60, 4, 5, 6. Is this associated with 70%, 80%, 90%, right? So PO2 is 60, you just kind of think 4, 5, 6, 7, 8, 9, so PO2 is 60, is a sat 90%. We like 60, 60 is fine, right? So, but if we start getting to the 50s, right, that's where I'm getting concerned. That probably means my sats are maybe in the 80s, right? My SpO2 might look great, but I look at the ABG report and it says the SaO2 is like 86%. So, well, shoot, those aren't correlating. Why aren't they correlating? Because maybe my patient has poor perfusion or something, or poor cardiac output, all right? All right, so remember the PO2, yeah, it's doesn't really participate much in oxygen delivery, only 0.3%, but when it starts getting higher and higher and higher, that starts causing a O2 toxicity. And on the flip side, when it's lower and lower and lower, that probably means my saturation is lower too, all right? All right, what are the advantages of a PO2? Why is a PO2 good? Well, it's accurate. It tells you exactly what my oxygen level is dissolved in my bloodstream. And also in the ABG, you can also grab the saturation to see exactly what my saturation is, the SaO2. The little caveat is it's only a snapshot. It doesn't look at, to do an ABG, you might get one every 4 hours, maybe every 2 hours if a patient's really sick, maybe every twice a shift, but mostly on a vented patient might be daily, and you can trend it daily, but you can't like trend it second to second, right, with an ABG. So what I'm saying about that is like if you just did a bed bath and you like sat them up and then they were coughing and then you had to do, then you had to change them again and then RT comes in, time for an ABG, right? And they grab an ABG, that PO2 is going to be low because they were using a lot of oxygen with that VO2, right? They're using a lot of oxygen in that state. Whereas if you had a SAT at that time, so they hit your PO2 is 47, your SAT it was like 84% when you're doing that whole bed bath situation, right? When it's 84%, it's like, oh, give them a second, they'll be fine, right? So that's the drawback. The PO2 is only a snapshot. It doesn't really tell you what was going on at that time, right? So that's just a pro tip for the night shift. If the RTs want to do ABGs usually before the bed bath, right? Or maybe like an hour after the bed bath, so that you get an accurate assessment. Okay, all right. When you get a PO2, it's not affected by your hemoglobin issue, any hemoglobin issues that usually are genetic, but there's no interruption there. You can actually get an exact value, right? And you can actually get the hemoglobin, again, hemoglobin saturation, the SaO2, okay? Your machine can grab a hemoglobin value. It's a little separate from PO2, but these machines that they have in the RT room, the ABG room, is actually like a really special machine. It's incredible what it does. You get labs within 10 seconds, right? It'll put a little drop of blood, just the size less than your pinky nail, and it gets in there. It can give you like 48 results, right? Not just the ABG results. It can give you electrolytes, it can give you ABGs, sorry, give you electrolytes, give you a CBC, it can give you coags, it can give you procalcitonin, it can give you all of that within 10 seconds, right? So it's an amazing machine. And laboratory, our lab actually has a backup downstairs when their big analyzers go down. They'll just run it in this machine here. So why can't we run like lights real quick when our patient's hyperkalemic? Because you can't bill for it. So that's the problem. You need to bill for your phlebotomist to come up and do their things. But we're trying to push so that the ICU, we can get a hemoglobin right away. Right? When you have a patient that has massive GI bleeding, it's like, oh shoot, their hemoglobin's obviously probably low. They came with 14, but I bet it's low right now. You could just run it right there, and 10 seconds later, you have a value, right? Same thing with electrolytes, right? It's like, oh shoot, they just went bradycardic. I wonder what their K is. 10 seconds later, you got a K, right? Not a big problem. Well, you have to do an ABG first, right? That can take a second sometimes, right? So what are the disadvantages? Are this right here. So you're poking into an artery. You can occlude that artery. They may only have one artery going to their hand, right? So you do what's called the Allen's test, right? If you've ever seen an Allen's test, it's supposed to be done with every ABG. I'm sure I've probably seen one. I probably see one done per year, but not to rat on the RTs. But you have good perfusion here, right? So it may occlude the radial and the ulnar, and you squeeze, and you see how it's all pale, and you let go of one, and I have perfusion, right? So that means I can then use this radial artery. If that didn't happen, my radial artery is providing all the blood flow to my hand, and then if that occludes, then I can lose the hand, right? So that's a downside. There can be collection errors. There can be little extra O2 bubbles, atmospheric bubbles in the sample. So RTs are all trained to make sure that is accurate. Okay, it is invasive. It's painful. Again, it's the mostly reported pain out of any ICU patient is an ABG. When you're doing the hemoglobin saturations and the bicarbs, those are usually estimated, right? It's not like an actual number. But what else? But the pH is accurate. The CO2 and the PO2 are measured by this machine. It's actually measuring the electrical differentials across what O2 does and what CO2 does, and gets you a value within again 10 seconds. You're getting all these different values punched out. Okay, and again, it is intermittent, so you can't you gotta assess what's going on at the time, and you can't trend it as well as you could like a saturation. Okay, so again, normal stats should be where? About 80 to 92%, right? Over here. And again, if you use the 4, 5, 6, 7, 8, 9 rule, so PO2 is 60, should be a saturation of about 90% right here, right? So PO2 of 80 to 100, yeah, that's 95, 97%, but that's the danger zone, right? Because 97% can mean a lot of high PO2s. Okay, there's a summary where O2 transport, again, 97% transports on the hemoglobin molecule. We are measuring the PO2 that's dissolved in the plasma, and we want to make sure that that is ideal, right? 80 to 100 for a normal patient, but in the ICU, we'll accept all the way down to what? Once we start getting below 60, that's when we're going to start getting a little more concerned and try to figure out if there's anything else we can do to resolve the issue.